Hello again, friends. So we are going to talk about sickle cell disease here, and sickle cell disease has a very large amount of complications that can come out of it. It is a chronic, lifelong disease, and there are physicians who specialize in this and spend their entire lives working with patients who have this particular disease. So I want to cover as much as we can about sickle cell disease, but make it relevant to the test and what you're probably going to see in real life. If you wind up becoming a hematologist working in a community where there's a high proportion of sickle cell disease patients, this by no means is going to be a comprehensive go over of sickle cell disease, but it will be enough to get you what you need on the test. And by any means what you should know as an internist, as a surgeon, but certainly not as a hematologist. Okay, so sickle cell disease is a hereditary autosomal recessive disease. And so by autosomal recessive, meaning both of your parents have to carry the trait, and it's a point mutation of the beta globin gene. So beta globin is one part of the globin tetramer. So there are two globins, or two beta globins and two alpha globins, making one full hemoglobin A, or one full globin A. If you have a defected beta globin, then you're going to have a defective globin A, and therefore a defective hemoglobin A. Remember, hemoglobin is just heme plus globin. So because you have a defective beta globin, you're going to have a defective defective globin A, which means you have a defective hemoglobin A. And what we call that defective hemoglobin A that's got that particular mutation in the beta globin gene, we call that hemoglobin S. So hemoglobin S, just think S for sickle cell. So what hemoglobin S is it's a functional red blood cell. It carries oxygen. It does everything a red blood cell should do, but what it does that a red blood cell shouldn't do, what hemoglobin shouldn't do, is it has a high preponderance to cause the red blood cell to sickle. And particularly this happens in times of hypoxia. So you're going around 100% oxygen level, you're fine. You're not going to have sickle cell disease or symptoms of sickle cell disease. However, you drop down to 90% oxygenation, which we all do from time to time, then the proportion of sickle cells are going to go up because you have that hemoglobin S. If you drop even further to 85%, which some of us do from time to time, it's going to be even more. And if it drops even lower than that, then it gets even worse. And depending on various other factors, the amount that you sickle can actually cause disease processes. And so the complications that come out of sickle cell disease and the crises are what we're actually concerned about in the sickle cell disease. We're not really as concerned about the anemia. We're more concerned about the complications. With anemia, we're carrying oxygen, we're producing hemoglobin. Certainly there are complications where that can be disordered, but with sickle cell disease, it's more appropriate to call it sickle cell disease because we're concerned about a wide range of complications that can come out of it, anemia just being one of them. So what we're most concerned about is, of course, this problematic sickling, because what sickling does is it causes what you could consider to be clots, except they're not clots because clots are platelets, and these are just red blood cells sticking together and sickling together. And so the primary issue is going to be vaso-occlusion due to the sickles. And this can be in various organ systems. So it can be in the brain, causing a stroke. It can be in the heart, causing an MI. It can be in the vasculature to the bones, causing osteonecrosis. It can be in the pulmonary circulation, causing what looks to be like a pulmonary embolism. So that is our primary concern with sickle cell disease, are the various complications that can come out of it. Hemoglobin S does also have a shorter lifespan. It only survives in the circulation for around 20 to 40 days, whereas a normal red blood cell with hemoglobin A will survive for about quadruple that, about 120 days. So patients with sickle cell disease will also have some features of hemolytic anemia. They will have a lower hemoglobin, but generally that low hemoglobin is not enough to cause frank anemic symptoms. But the patient with hemoglobin S with sickle cell disease, will have some features of hemolytic anemia, and it can be the range can be from relatively normal or mild to very severe. So they do have some features of hemolytic anemia, but I really want to stress that the major concern with sickle cell disease are the complications and the crises, the so-called crises that come out of it, not so much the anemia. Okay, so 1 in 12 African Americans carry the trait, and sickle cell disease is primarily a disease in the U.S. of African Americans. So certainly anybody can carry the sickle cell trait, but in the U.S. it's primarily African Americans, and I can almost guarantee you that on the USMLE your patient is going to be black. In your clinical practice, when you see sickle cell disease, the majority of your patients are going to be black. So you have to keep that in mind. But anybody can get sickle cell disease. As a matter of fact, the actual mutation on the beta globin gene is having the trait, so having one gene that's defective, but the other gene that's normal, that's actually helps with survival against malaria. So that's evolutionarily why we tend to see this in blacks and to a lesser degree in Southeast Asians and Mediterraneans. So 1 in 12 African Americans carry the trait. Only 1 in 500 carry the disease. That's still a lot. That's, 0.2%? So that's a good amount. Okay, so sickle cell disease is tested at birth by suspicion. Generally, the rule of thumb is if there's a family history or if the patient, if it's a black child. So I would test either of those. But usually patients who have a family history, again, they tend to be black. So those are the children that you should test at birth. And certainly testing at birth will help you establish a diagnosis, but it doesn't necessarily diagnose it all the time. So when you're diagnosing sickle cell disease, it's important to know that the best initial test is a peripheral blood smear. The most accurate test is hemoglobin electrophoresis. So when you have a baby, a newborn baby, you might not see the sickle cells on a peripheral blood smear. Why? Because they're not producing hemoglobin A as much. They're still producing hemoglobin F. So you're not going to see the defective beta globin, because in hemoglobin F, remember, it's alpha 2 gamma 2. With hemoglobin A, it's alpha 2 beta 2. So if you have the defective beta, that's not going to show up in hemoglobin F. So you may not see any abnormalities on the peripheral blood smear. So sickle cell disease is tested at birth, but you may not get a positive test on a newborn. So that's important to remember. So it is the best initial test, but by no means is it the most accurate test. That would be a hemoglobin electrophoresis, and that actually divides up the globin proteins, and we would actually see the defective hemoglobin. Okay, the symptoms and complications will usually manifest by 6 months of age. What happens at 6 months of age? 6 months of age is when the production of hemoglobin F starts to drop off, and the production of hemoglobin A, adult hemoglobin, increases. So at that point, the child becomes more reliant on having the beta globin, because their hemoglobin is going to be alpha 2 beta 2 rather than alpha 2 gamma 2. And since they're not producing as much hemoglobin F, if they are sickle cell disease, then their primary hemoglobin that they have is going to be hemoglobin A, and it's going to actually be the defected form, so it'll be hemoglobin S, which is the defected form in sickle cell disease of hemoglobin A. So, so that's why the symptoms will usually manifest by 6 months. But the first 6 months of life, usually there's no manifestations. Functional asplenia generally occurs by early childhood, and so it's really important to keep an index of suspicion in patients that are Black who present with severe infections. If they haven't been definitively tested for sickle cell disease, it's going to be really important to test them, particularly if it's joint infection, bone infection. Those things aren't as common in children, so you should be keeping a high index of suspicion. So it's going to be the encapsulated bacteria, because if you don't have your spleen, you can't fight encapsulated bacteria. So what we're thinking is pneumococcus and Haemophilus. And the approach to therapy in general with sickle cell patients is going to be the prevention of sickle cell crises, which are acute complications of sickle cell disease, and then the various complications of sickle cell disease, which are some of the more long-term complications of the disease. Okay, so what are these crises of sickle cell disease? So we have 3 different types. So there's the vaso-occlusive crisis, and there's various different ways that this can manifest, and it is what it sounds like. It's vaso-occlusion. So this is an acute occlusion, and it can happen at various points in the circulation. It can happen in the kidneys, it can happen in the brain, it can happen really pretty much anywhere. And the intensity of the pain is going to reflect the severity of the necrosis to that particular organ. So what's important to remember is that any patient with sickle cell disease, if they come in with pain, you have to keep a high index of suspicion for a possible vaso-occlusive crisis. That's generally what's going on, and what we want to do is minimize the effects. So these vaso-occlusive crises are they tend to be a really vicious cycle. So what you get is you get the sickling, and that causes an occlusion, and then you have pain, and pain generally causes the patient to become hypoxic, and then the hypoxia causes more sickling, and that causes more pain, and that causes the patient to become more hypoxic, and so it's this really vicious cycle. And when you add the inflammation in the surrounding tissue, and that's causing a local acidic environment, and that's going to promote more sickling. So it's really important to break that cycle. So when a patient with sickle cell disease comes in with any kind of pain at all, the best therapy is going to be supplemental oxygen and then hydration. Supplemental oxygen is going to be good to make sure that their oxygen level is up, and then the hydration is going to be good to make sure that they're maintaining a good fluid status. It's also important, I should have probably put this second rather than fourth, ample pain meds. That's really important, because remember, part of that vicious cycle is the pain. The pain is going to cause them to become more hypoxic. So making sure that they have pain meds right away. If you have a patient with sickle cell disease and they are in pain, you do not doubt that pain at all. You're going to be giving them whatever pain meds you have available. I would lean towards the stronger pain meds. So even something like morphine or fentanyl would be fine. And then if it's very severe, you can go towards transfusion. As a matter of fact, the very, very severe crises, I would definitely transfuse. So oxygen, pain meds, and then transfusion and hydration. And the most clinically significant vaso-occlusive crisis, not that the rest of them aren't significant, but the most clinically significant and sort of unique vaso-occlusive crisis is acute chest syndrome. Anyone can get a stroke, anyone can have a heart attack, but this acute chest syndrome is very unique to sickle cell disease. We'll talk about it in a little bit. So splenic sequestration, crisis, and infection. So yes, we talked about how everybody tends to autosplenectomy by early childhood, but a splenic sequestration crisis is different. This is an acute, painful enlargement of the spleen, and what happens here is the spleen becomes, there's sickling in the circulation to the spleen, and the spleen is going to start trapping red blood cells. And it actually traps so many red blood cells that it can cause circulatory failure. So you can actually go into hypovolemia. So the treatment here, if you have, and it's going to be very obvious, when you have a patient with splenic sequestration crisis, if they are black or have a history of sickle cell disease, it's going to be very obvious because they're going to have a massive spleen. And so the treatment is going to be supplemental oxygen, hydration, transfusion, and antibiotics. Why do we give them antibiotics? Because they may be infected. So particularly if they have a fever. And the third or fourth generation cephalosporin tends to be what we use in any kind of sickle cell disease complication. That being said, with any infectious disease in patients with sickle cell disease, if a patient with sickle cell disease ever comes in with a fever, you should jump right to antibiotics. Don't hesitate to use antibiotics in a sickle cell disease patient who has a fever. Okay, and then aplastic crisis is just a very acute aplastic anemia. This tends to be triggered by some kind of infection. Usually it's parvovirus B19. And this is an acute aplastic anemia. These patients come in, they are pallor, fatigue, tachycardia, all the cardinal signs of anemia. And this tends to only affect the red blood cell line. And the treatment, of course, here is going to be transfusion because these patients are going to be have a dropped hemoglobin and hematocrit. So you treat these patients with transfusion. Okay, so that acute chest syndrome, we'll go back to that. So remember that is a vaso-occlusive crisis. And the symptoms of acute chest syndrome are fever, cough, which can be productive or non-productive, chest pain, and dyspnea. What does that sound like? That sounds exactly like pneumonia. And as a matter of fact, there is no way you can clinically tell that this isn't pneumonia. You can get a blood culture and a sputum culture, but that's not going to be back until 2 days later. So really, you're going to treat acute chest syndrome like pneumonia, except that if you know that the patient has sickle cell disease, then you're going to go right to antibiotics. You're not even going to do a chest x-ray. Why? Because you're going to be doing the antibiotics anyway. It doesn't matter what that chest x-ray looks like if a patient with sickle cell disease has fever, cough, chest pain, dyspnea. This is acute chest syndrome, and we need to treat it as if they may possibly have pneumonia because that is another cause of vasoocclusion because they have an infection. So you're going to treat a sickle cell disease patient who has symptoms of pneumonia. Sure, you can get a chest x-ray, but the best first step is going to be IV antibiotics, pain meds, fluids, and oxygen. You see this pattern here. And whenever a patient with any kind of crisis from sickle cell disease comes in with pain, you're treating them with antibiotics, pain meds, fluids, and oxygen. Now, you may do transfusion or exchange transfusion, and as far as transfusion, the difference between simple transfusion and exchange transfusion, you're taking blood out of the patient and putting blood into the patient. Simple transfusion, you're just putting blood into the patient. Transfusion itself, just simple transfusion, has been shown to clinically improve outcomes in patients with acute chest syndrome when given early. So transfusion would be another thing to add to that list. The thing with transfusions, though, is with patients that have sickle cell disease, if they're getting chronic transfusions, they are at risk for hemochromatosis. But acute chest syndrome, the important thing to remember, if they are a diagnosed sickle cell disease patient and they come in with those signs that we would normally associate with pneumonia, you are going right to management, and you're going to give them antibiotics, pain meds, fluids, and oxygen. Now, certainly, you should get sputum and blood culture because, you want to know if they have pneumonia or not, but you've got to treat them empirically and presumptively with antibiotics. So all acute chest syndrome patients should be admitted, of course, And we want to ensure that they're doing incentive spirometry, which is sort of that little thing that you blow into and it makes the little ball go up into the desired range, and the patients can kind of play with that. And that's good to make sure that they're expanding their lungs, because again, this is really important that you remember that vaso-occlusion is caused by acidic environments, hypoxia. And so if they're getting their lungs aerated, you're going to reduce that hypoxia and you're going to reduce the vaso-occlusion. Also important to avoid overhydration. That's really for any patient. Doctors have a tendency to pump fluids into patients that don't need it. Certainly if they've got good blood pressure, good fluid status, you don't need to necessarily use IV fluids. You can do oral fluids if they're able to take them. Okay, so here's some of the complications of sickle cell disease, and certainly this is not a comprehensive list, but it's a list of the ones that, in my opinion, come up the most on the USMLE and are the most commonly seen in sickle cell patients. So growth defects, and that's simply because patients being chronically ill with sickle cell disease in childhood, being chronically ill in general is going to lead to growth defects. Not to mention if they have any kind of bone infections, that is another thing that can lead to at least a height defect. Stroke and transient ischemic attack are a possible complication of sickle cell disease, again because of the vaso-occlusion. Blindness, which would be vaso-occlusion of the ophthalmic artery or vein. Pulmonary hypertension, this is a big one for sickle cell disease. So you can have sort of a subclinical acute chest syndrome where you're getting little tiny occlusions in the microvasculature, so you might not notice it, but it increases the work that needs to be done by the right ventricle, which pumps against that gradient, and so you can get pulmonary hypertension and secondary right ventricular hypertrophy, which would be manifested the exact same way as anybody with pulmonary hypertension. And so that you would just treat that the exact same way as anybody else. You can use PDE5 inhibitors like sildenafil. Osteomyelitis is a very notorious complication of sickle cell disease, particularly of the long bones. So you're thinking more in children, it's going to be fingers and feet. With adults, it's going to be more femur and humerus. But it can be anywhere in anybody with sickle cell disease. Septic arthritis, that's another one that can come up in anybody too, though, but higher case incidence in sickle cell disease. Abdominal infarction, again, these are all vaso-occlusive manifestations. Cholecystitis and gallstones, that's because of the hemolysis, which happens at a higher rate. Nephropathy, priapism, which would be, again, that's another vaso-occlusive crisis. This is in men. Erection of the penis lasting longer than 4 hours. The management here is emergent and surgical. You're just going to drain the corpus cavernosum. And then skin ulcers are dermal occlusions. So these are all things to keep in mind as long-term complications for sickle cell disease. So here's osteomyelitis in sickle cell disease, and this isn't always what you'll see, but it's a very characteristic finding in sickle cell disease among some other diseases, and it's what we call a bone-in-bone deformity. So they have osteomyelitis, and it looks like this is the humerus here. I can't really tell because it only shows part of the bone, but here you can see the outer part of the humerus, and then you've got this sort of parallel, what they call bone-in-bone. Okay, what's the number one cause of osteomyelitis and sickle cell disease? It is Staph aureus, just like everybody else. Don't get confused by that. Salmonella is what people often answer, and it's the wrong answer. It's a unique cause in sickle cell disease patients, and certainly it happens at a higher incidence in sickle cell disease patients, but it's not the most common. Most common is Staph aureus, just like everybody else. Okay, so long-term management of sickle cell disease. What do we do for these patients in the long term? How do we take care of them? first and foremost, like any lifelong chronic illness, patient education is going to be very important. And it has a particular role in sickle cell disease because these patients can have those major sickle cell crises where they can have something that can kill them. So they need to be very aware of signs of infection. If they feel down and out, they should be taking their temperature. Worsening anemia, so if they start developing pallor, if they start having blanched fingernails, if they start having worsening fatigue, they should definitely be seen. And of course, attention to pain. And don't make them paranoid about their pain, but make sure that they know that pain that lingers or worsens despite taking their medications that they're prescribed for pain, like NSAIDs or opioids, if that pain lingers or worsens or just doesn't seem to go away, they should not feel ashamed to come into the hospital, because any pain in sickle cell disease is not trivial. It is pain that needs to be addressed. So make sure that they are not afraid to address their pain on the side of caution, which would be to come in and have a professional address it. Oral pain management, how do we address them long term? Well, in the short term, we give them IV opioids. We don't do that for at home. So NSAIDs, ketorolac is a good one, prescription strength NSAID, or opioids, either or are fine. Over-the-counter pain relievers are good too. You should really educate these patients to sort of grade their response to their pain based on the severity. So don't use opioids if it's just a minor pain. Start out with maybe a hot or cold compress. If that's not getting rid of it, move up to an over-the-counter pain reliever. If that's not getting rid of it, then move up to one of your prescription strength drugs, because we don't want the patients to become dependent on the drugs, and we also don't want the patient to not respond to the drugs. So we want adequate but not overzealous pain management. But the patient should be, again, not shy to address their pain. So it's really sort of tedious to get to that appropriate balance. Hydroxyurea. Most patients with sickle cell disease are on hydroxyurea. Why? It increases proportion of hemoglobin F. It increases the production of gamma globin. And gamma globin is that part of hemoglobin F which pairs up with alpha globin and makes the fetal globin. And patients with sickle cell disease have absolutely normal hemoglobin F, and it doesn't sickle. So the more hemoglobin F you make, the less defective hemoglobin S you're going to make. Prophylactic penicillin is going to be good for preventing any kind of infections, and we generally start kids on that, and it's for life. Folate supplementation is going to be good in any disease where there's hemolysis, and in sickle cell disease you do have an element of hemolysis. The blood cells are not lasting as long. So you'll want to replace, or you want to supplement them with folate, because in general, if you're having more production of red blood cells, you're having more cellular turnover, folate's going to be important to prevent from a macrocytic anemia. And then what's most important is preventing infection. So that's sort of the overall theme in long-term care, is preventing infections and preventing pain. What we're worried about with the pain is we're worried about both what may be causing the pain. So maybe they have an infection, maybe they're having sickle cell crisis, maybe it's just they stubbed their toe. We don't know. But what we do know is that when you have pain, regardless of whether it's caused by a sickle cell cause or not, pain causes an acidic environment, and it causes hypoxia to one degree or another. So any pain needs to be addressed, because what you can get out of pain is a risk factor, hypoxia, acidemia. You can get a risk factor for sickling. And so pain needs to be managed not just for the possible cause of it, but the possible effects of it. And then, like I said, adherence to immunization, that's going to be very important. They should be getting all their immunizations unless otherwise contraindicated. So particularly the pneumococcal vaccine, because that's what the splenic sequestration, autosplenectomy is going to make them at risk for is pneumococcus. They should also be getting meningococcal vaccination and influenza, as anybody should. Influenza vaccine every year, and meningococcal vaccine, generally that's given in early childhood and again at some point in adulthood. And that is it.